I want to welcome everyone to the Fifth Avenue Synagogue weekly Sunday night lecture series. We hope everyone is well. We definitely miss everyone. We look forward to, please God, hopefully soon coming back together in shul and the way it's supposed to be, even though we're trying to make the most of it. I just wanted to mention to everyone two things that, you should realize that the staff in the synagogue are working very, very hard to create some level of normalcy and to service the needs of the community to the best of our ability. And we have davening, virtual davening at least 3 times a week. We have one tomorrow morning, Thursday mornings, and Erev Shabbos. We have multiple classes each day that are available to everyone in a whole variety of topics and levels. We have video clips that we send out daily and Divrei Torah. And so we're trying to cater to everyone's needs and to make this difficult situation just a little bit sweeter to the best of our ability. And if anyone has any ideas what we could do for you and how we can enhance the quality of your lives at this time, please don't hesitate to reach out to us. We also want to use this opportunity to thank the staff. We realize that the staff is working extremely hard. Rachel and Sheila and Tanya and Maggie as well in the office, and Jacob Gold, the president. Everyone's working very, very hard to put together the programs. Nothing of good quality in life happens by itself. It's always a tremendous amount of effort. So I wanted to use this opportunity to thank everyone, the staff who are working so hard, and the community still being part of the community and joining us. And I think the main thing for all of us to get through this is the connection, the human connection, that we know that we're not alone and that others there for us. I think that's critical to allow us to get through this challenging time and to being able to meet together in person once again. So I thank you all for joining us, and please turn your attention to Rachel, who's going to introduce and moderate this evening's program.
Thank you, Rabbi, and thank you for your excellent leadership. Well, welcome everyone. So nice to have this chance for us to be together on a Sunday evening, at least virtually. 6 weeks ago, my father, infectious disease expert, Dr. Gregory Storch, joined the Fifth Avenue community in the wake of a startling new illness that was rippling across the globe to give us a COVID 101. Tonight, he's here to give us a COVID-19 update. We hope that the next time he joins us, it will be for a COVID-19 retrospective.
Great.
When he spoke first, we were trying to get our arms around exactly what was going on. What exactly was the illness? Where had it come from? What were the best ways to avoid risk? Today, we're in a new phase. We see the reopening of our society on the horizon. As we balance our health with the health of our economy, we're grappling with many new challenges and questions. Are antibody tests meaningful? Are treatments working? How close are we to a vaccine? Tonight, my dad, Dr. Storch, will address some of these questions and perhaps consider some of the practical implications of the risk that remains. Many of you have already submitted questions by email, and after my dad speaks, I will present these questions. You may also submit questions through the chat function on Zoom, and we'll try to get to as many questions as possible. For those of you who were not able to join the first session, my dad, Dr. Storch, is the Ruth L. Siteman Professor of Pediatrics and a Molecular Microbiology at Washington University School of Medicine in St. Louis. He is past chief of the divisions of Pediatric Infectious Disease and Pediatric Laboratory Medicine. He was an Epidemic Intelligence Service Officer for the CDC in the Louisiana Department of Health in New Orleans, and an infectious disease fellow at WashU. He joined the WashU faculty in 1981. He's past president of the Pan American Society for Clinical Virology and an associate editor of the Journal of the Pediatric Infectious Diseases Society. He is currently working with the OU on health and safety guidelines related to COVID-19. Dad.
Thank you. And most important, I'm Rachel's dad. So good evening. I'm speaking to you from St. Louis, and I'm going to start with some opening remarks for about 10 or 15 minutes, and then really open things up to questions, and we'll go from there, and we'll see where we want to go. So I do have some slides. Let's see if we can bring those up. I have to share the screen, and I'm getting a message, host disabled, attendee screen sharing. So I think you need to do something on your end.
Sheila, can you go ahead and enable the screen sharing function?
Okay, I think we're making progress. That looks good. Okay, here we are. So I will go ahead and start. And as Rachel said, some weeks ago, we did another session that, excuse me, just 1 minute. Okay, some weeks ago, we did another session that was really COVID 101. And I'm going to assume that everybody remembers everything that I said then. No, I'm just kidding. Really think about your questions, and any question you'd like to ask, I will do my best to try to answer. What I'm going to do in these opening remarks is really update developments since the last time we spoke, and that will be in the area of epidemiology. I'll talk about diagnostic tests. I'll talk about treatments, including vaccine, and I'll talk about the future. So let's compare the numbers that I presented the first time with the numbers now, and these change, so they have to be updated every day. I have today's numbers. So we've gone from a little under 1 million cases in the world to about 3.5 million recorded cases. Of course, that we know that's just a fraction of the actual cases that have occurred. We had 46,000 deaths at that time. Now we're up to 245,000 deaths worldwide, and the cases involve 187 countries, virtually every country on the globe. Our country has now emerged clearly as the world leader in COVID-19, a somewhat dubious distinction. Back then, there were a little over 200,000 cases. Now we have recorded 1.1 million and beyond, and 66,760 deaths as of today. And it's still true that New York and the tri-state area are really the main hotspot in the United States. The disease is not distributed evenly by any means, and Massachusetts is another hotspot. Illinois, Michigan, to some extent Florida, are all areas of activity. Some of the rural areas in the country have much less activity than the urban areas. New York State is now up to beyond 300,000 cases. New York City, more than 172,000 cases, and tragically, more than 18,000 New Yorkers have passed away from this infection. And once again, I want to say that that's a minimum estimate, because those are the numbers of deaths that are recognized, proven, or highly suspected of being related to COVID, but undoubtedly there have been a number of other people who passed away in some way related to the disease that's not yet officially recorded. Increasingly, I think we're becoming aware of special problems in the distribution of this disease, areas where it really settles in and causes disproportionate effects. I'm not sure that's exactly true of healthcare workers, but certainly healthcare workers have been affected. This is obviously a very serious problem. We can't have our healthcare workforce decimated or demoralized, because that would compromise our ability to respond to this disease. And one of the really unfortunate aspects of this disease has been that we haven't always had perfectly adequate personal protection for healthcare workers. I do think that situation is improving, and it really is important for this to be a very, very high priority to make our healthcare workers as safe as possible as they go about the dangerous job of caring for patients with active COVID-19. I think we've also become aware of how interdependent we are in our society, and how there are numerous other groups that are carrying out vital functions that put them at risk of this disease. And I think about grocery store clerks and others, just for starters, who are in contact with the public. We couldn't function as a society without them, and they are at increased risk of disease. And our first responders, our mailmen, our sanitation workers, our internet workers, numerous others who are interacting with the public and thereby taking on increased risk. Now, with a contagious disease like this, especially one that spreads by the respiratory route, the disease does very well in confined institutions. And so let's talk about nursing homes. The nursing home is made for COVID-19 outbreaks. People are in close contact with each other. They depend on workers for their care. The workers may have other jobs and work at other nursing homes and may bring the virus into the institution, and it can spread readily. And what we've seen again and again is that as soon as 1 or 2 cases are detected in a nursing home, whether it's in the residents of the nursing home or the workers, if we go in and do a survey in that nursing home, there are many more individuals infected than we were aware of. And it is difficult to contain it. It tends to spread throughout the nursing home and other extended care facilities. We become aware that certain occupational groups, particularly meatpacking plants, are at particular risk. And why is this? Because these are dangerous work environments with crowding, with workers shoulder to shoulder, being together for hours at a time. And once again, just made for the transmission of a respiratory virus. So once a respiratory virus gets in, it's very hard to contain its spread. I didn't list on this slide, but ships are certainly another kind of institution, a closed environment, sharing air, sharing personal space. And so this applies to cruise ships, and it applies to military ships as well. We've seen very serious outbreaks in some military ships, both in this country and elsewhere. And finally, to nobody's surprise, prisons are very vulnerable to infectious diseases, particularly ones that spread by the respiratory route, because there may be crowding and little ability for people to prevent infection from spreading. And so we know that there are a number of large prisons in this country, in the New York area and throughout the country, where this disease has gotten established and caused hundreds of cases. Prisoners are involved, the staff are involved. And of course, all of these things, the nursing home outbreaks, the meatpacking plant outbreaks, the prison outbreaks, are of concern not only because of the individuals in the institution who are infected, but because they represent risk to the surrounding community. And this is proving to be an entree for the virus into rural communities. There are many rural communities that have large meatpacking plants or large prisons, and those communities become at risk when one of these outbreaks takes place. So let's talk about the tests that are out there for COVID. That's an area for very active discussion right now because of the introduction of antibody tests. So we've been aware for a while of the viral tests. These are called molecular tests. They use a technique called PCR, polymerase chain reaction. And these are tests that detect nucleic acid, or the genetic material of a microbe, and in this case, the RNA of the virus. They are mainly done on a nasal swab, but they can be done on a throat swab or various other specimens. And that swab then has to go into transport media, that is a little liquid, to keep it stable. And that is transported to a laboratory. The laboratory carries out the test. The test itself really doesn't take that long, anywhere from about 4 to 6 hours for the standard tests to less than an hour for rapid versions of the PCR tests that have come online in the last few weeks. Now, it's very important to know what these tests do and what they don't do. So what they do is they detect the presence of the virus, and they just detect the presence of the virus at that time. So they are positive starting 2 or 3 days before a person develops symptoms. If you somehow had a way of knowing that somebody was about to develop symptoms and you tested them, they would have a positive test a day or two before. And then the virus is at its highest level for the first few days of illness. So that's when the tests are most likely to be positive. And then the level of virus declines over 2 to 3 weeks. So the tests then become negative after several weeks. There are some individual cases where the tests may stay positive for longer than that. But once you go out beyond the illness, these tests will become negative. Now, it's also important to recognize that even at the peak of illness, sometimes these tests are not positive. In other words, they are falsely negative. Now, why is this? It partly is the nature of the specimen. You're putting a swab back into the nose and doing it basically blindly. And one time you may get a very good sample, but another time the swab may go back there and it may not get such a good sample. And the other reason is sometimes people just vary in the amount of the virus that's present in their secretions. So it's estimated that probably about 20%, maybe even more percent of the time, these tests may be falsely negative. So if a person, and this is a lesson for physicians and also for non-physicians, if a person has illness signs that really are like the signs of COVID and has a negative test, you should not conclude from that that the person doesn't have COVID. Maybe they don't, but maybe it's a false negative, and it often is worth repeating that test in a few days. And I think we've all heard many anecdotes of individuals who have 1, 2, or even 3 negative tests, and then later on have a positive test. Now, the testing that is coming online now are antibody tests. These are fundamentally different from the viral tests because these, rather than detecting the virus itself, they detect antibodies that a person makes. So antibodies are proteins that our bodies make in response to exposure to a foreign substance, including a microbial agent. It takes a little while for those antibodies to build up, generally about 10 days or so. So for the first 7 to 10 days of the symptomatic phase of the infection, the antibody test will be negative. But then the antibody levels rise and become detectable by one of these tests. And those antibody tests then can stay positive for at least for months. And in some cases, for some types of infections, even for the lifespan of an individual. For example, if a person has measles, then usually measles antibodies can be detected in that person's blood even decades after the initial infection. We don't know in the case of COVID whether these antibody tests will stay positive for a few months or for years or even for a lifespan. And what they indicate is that the person has either very recently or in the somewhat more distant past had the infection. Now, of course, since this infection has only been with us since January, then it has to have happened since January. So we know that if a person has a positive test, they have experienced COVID or infection with SARS-CoV-2 sometime during the 4-month period of this outbreak. Now, a very, very important question that we don't know the answer to is whether detecting antibodies in a person's blood means that they are immune to another infection. With most viral infections, once a person has had the infection, they are immune at least for a period of months after the infection, and sometimes, as in the case of measles, for example, for their lifetime. But that's not always the case. So we are optimistic and we're hoping that a positive antibody test means that a person is immune, but we don't have that answer at this point in time. I think we will get that answer over the next couple of months, but simply some time has to pass. We have to have an accumulation of people who have experienced the infection, and then we have to see what happens to them. Do they have true second infections or not? Now, the last point on the slide is uneven quality. Now, this, unfortunately, is a very serious problem that has developed just since the tests have been introduced. And I really have to raise some questions about the role of the FDA in this. The FDA has done something that I don't know if they've ever done before, and that is they have decided that they will not examine the quality of these tests. They will just allow them to be marketed. And all the manufacturer has to do is notify the FDA that they are about to start selling the test and they can do it. So there are now something like 100 different antibody tests made by different manufacturers on the market. And we know already that the quality of these tests is very variable, that some appear to be quite good and others are terrible. And it's really true that when you're dealing with a bad test is worse than no test because it can give misleading information. So this has really marred the landscape of antibody testing, and it's very critical to know that your blood, if you do one of these tests, and they are performed on blood, that the blood is being tested using a reputable test. Now, without making any endorsements, but Abbott Laboratories is a very reputable manufacturer of serologic tests, and they have introduced an antibody test that appears to perform very, very well. And as I say, I don't say that in the interest of specifically endorsing one manufacturer, but that test is widely distributed at this point. And if you determine that your blood is being tested with the Abbott test, then that's good. That seems to be a reliable result. Other laboratories, say the Mayo Clinic that serves as a reference laboratory, and some of the other national reference laboratories also do reputable tests. But you do have to make a determination of whether your blood has been tested with a accurate test or not, and that's not always so easy to do. Okay, let's talk about treatment. And there has been some exciting developments there in the past week, and I'm referring mainly to the first item on the slide, the drug remdesivir. So what is remdesivir? Remdesivir is a true antiviral agent. This is a drug which interferes with the replication of the virus. It gets into an infected cell and it basically gums up the works for the virus and makes it so that the virus cannot reproduce itself. And it's quite active in the laboratory. We have been waiting with bated breath for the results of clinical trials. Before this past week, we had some results from uncontrolled clinical trials. In other words, where a series of patients who got the drug, but there was no comparison with a group of patients who didn't get the drug. But last week, the results of a trial sponsored by the National Institutes of Health were released. And this trial was a very, very good trial from the standpoint of study design, in that a large number of patients received the drug, an equally large number of patients received a placebo. Nobody involved with the trial knew whether an individual patient was getting the actual drug or placebo, so this minimizes bias in determining the outcome. The results were generated and analyzed, and preliminary results released this past week. And what it showed was a statistically significant decrease in the time to resolution of the infection in the group that got remdesivir. There was also a trend towards decreased death rate in the group that got remdesivir, but it was not what we call statistically significant. In other words, it could have been explained by chance, but it may represent a real effect as well. Now, why are we very happy about this? Because up until now, we haven't had a confirmed tool to use to fight this infection. But this is a real tool, and this gives us something to work with. It, according to the clinical trial, is not going to solve all of our problems. It shortened the disease. It didn't completely eliminate it. But I think there's even more grounds for optimism, because it's probably the case that the way the drug was used in the clinical trial was not the absolute optimal way to use the drug. And what I'm referring to is that in almost all instances, the earlier in the course of infection that an antiviral drug is started, the more effective it will be. And in this trial, the drug was not started especially early. So if we instead start the drug as soon as the patient is admitted to the hospital, for example, then I think it's quite possible that it'll be more effective than it was in the clinical trial. Now, I do want to mention it is a drug that is required to be given intravenously, so it will not be easily applicable to outpatients, but we certainly do intravenous therapy in the home, and that may come about as well. So time will tell just how much of a difference this makes, but I think it really is a significant advance. Now, the next mysterious set of letters and numbers on the slide, EIDD 2801, are cousin of remdesivir. Cousin of remdesivir is another drug not as far along in development, has not been in humans yet to my knowledge, but it is equally active as remdesivir and has attracted a lot of interest because it can be given by mouth. So this may be an oral version of remdesivir. It is possible that it might even be possible to combine it with remdesivir. So another, I think, interesting prospect for an antiviral drug. Okay, let me say a little bit about chloroquine and hydroxychloroquine, which have gotten a lot of attention. And there is good reason to think that they might have an antiviral effect because of things that we know about the way they act on cells. But I don't think anybody thought that, any scientist anyway, thought that they were going to have a dramatically important effect. They might have an effect that might be helpful either for treatment or maybe even for prevention or for early treatment after exposure. But now, as we really look into the literature that supports the possible effect of these drugs, we realize that the literature is very scanty. And I would say at this point in time, we do not have a lot of evidence that chloroquine or hydroxychloroquine will be effective, but we don't know that they're not either. And clinical trials are underway that are well designed that will give us information before too long about whether these drugs are helpful. Right now, some physicians may choose to treat patients with the drugs. They are safe drugs. They've been around for a long time. We know a lot about how to use them. And I would say it's not unreasonable for a physician to begin a patient on hydroxychloroquine or chloroquine at a time when they think the patient is infected with COVID-19. What I think we're moving away from is using those drugs simultaneously with the antibiotic azithromycin. You may have been aware that earlier on, a lot of patients were treated with hydroxychloroquine plus azithromycin. The problem is that both hydroxychloroquine, or chloroquine for that matter, and azithromycin each can have some toxicity directed against the heart, having to do with the transmission of electrical signals within the heart. And while neither one of them by themselves would be considered dangerous, combining them when they both have that effect is probably not a good idea. So I would say use chloroquine or hydroxychloroquine, but don't use it along with azithromycin. Now, the next drug I'll mention, probably few have heard about, tocilizumab. This is a drug that would be used in very severely ill patients, and it's a different kind of drug. Rather than being an antiviral drug, it's directed at quieting down the inflammation in the individual who's sick. We have an idea that some of the damage that happens to a person who's sick with COVID may happen because of innocent bystander effects from the person's immune response to the virus. And tocilizumab is a drug that can quiet down the immune response. And right now, we only have anecdotal reports about it. There are some enthusiastic anecdotes, but I think it's fair to say, once again, that we really don't know whether it's effective or not. The Infectious Disease Society of America, in its recommendations, recommends that this should only be used in the setting of a clinical trial. Now, let me end with talking about convalescent plasma, which has also gotten a lot of attention. And this is the idea that when a person experiences an infection like COVID, their body responds and makes antibodies. Those antibodies are in the plasma portion of blood so that you can remove the person's blood, separate the plasma, and then infuse the plasma into a person who might be sick with COVID, and that would have a beneficial effect. This has been done for many years. It was actually done in the pre-antibiotic era and was somewhat effective. It was done and shown to be effective for Ebola. It was tried in the case of SARS. And so there is a lot of interest in trying it for COVID. And the FDA has given permission for doctors to use it under supervised circumstances. We do not know at this point in time whether convalescent plasma is effective or not. We hope that clinical trials will allow us to make a determination, but right now, individual physicians may decide to administer convalescent plasma. That requires other individuals to go to a blood bank and donate their blood. These are individuals who have recovered from COVID. And if I gave the impression that those are individuals selected for an individual patient, that's not the case. Individuals go and give plasma, and then the Red Cross can release it for a patient, but there's not a specific relationship between the donors and the patient getting plasma. So I think we have one significant tool that I think will help us a lot. That's remdesivir, and we have several other possible tools that we will learn more about over weeks and couple of months to come. Now, let's talk about vaccine. Vaccine is different from treatment. Here we're talking about something that would be given before a person is exposed, with the intention that it would induce an immune response and make the person immune to the infection. So we're all familiar with polio vaccine or measles vaccine and so forth. These have been extremely successful in controlling many very serious diseases. Well, there is lots of work going on to develop a vaccine. Because this infection, I talked about this last time, is somewhat similar to the disease SARS, which occurred in 2003, and somewhat similar to the disease MERS, which began in 2012, there is a body of research on various types of vaccines for those kinds of related coronavirus infections. And so those vaccines have been altered to be effective against SARS-CoV-2, and they are being tested. There's something like 70 candidate vaccines out there, and something like a dozen that are already in clinical trials. The NIH has a couple of trials going, and there's been a lot of publicity about the Oxford University in England has a vaccine that looks promising that is in clinical trials as well. Now, as Anthony Fauci has talked about and others, best case scenario is 12 to 18 months for one of these vaccines, because they have to be tested to determine that they're safe and to determine that they actually work. They have to go through a regulatory process, which will be expedited, but nevertheless, they have to go through that process. And then there are all the issues of scaling up to manufacture a new vaccine and to distribute it and to figure out where it should go and who should get it. So I would say under very best case scenario, 12 to 18 months, meaning that we will go through that period, the next year or so, without a vaccine. And it's only a vaccine that can really eliminate this infection from our landscape. Otherwise, it's as I'm going to say on my next slide, it's likely to be with us. So let's talk about the future. And I purposely left this slide blank. The future, I think, is quite uncertain because we're dealing with a new virus, and I don't think anybody on the globe can really predict with certainty what the behavior of this virus is going to be. But I think we can say that in light of the large number of people around the globe that have been infected, the fact that we see that this virus is very contagious and can move around quite effectively, I think it's unlikely that this virus is going to disappear on its own, or even in response to our control measures, the way SARS did in 2003. SARS simply disappeared. We don't really know why, and it's miraculous. Likewise, Zika went away after 2016, and we don't really understand why that happened. So there's a tiny possibility that this one might disappear on its own too, but I think it's unlikely. And we have to recognize that if it doesn't disappear on its own, and if we don't have a vaccine, then it's going to be with us. Now, the hope, the most optimistic hope, is that we will get it under control in all around the United States, the way some other countries have had some success in getting it under control. We still don't know, though, whether any of those success stories are going to be durable and whether they can really keep the virus under control. So I think under the best case scenario, we're going to have a lot of COVID activity over the next several months. We will be really battling it, hopefully on the downside of the epidemic curve, but still battling it, still dealing with outbreaks in nursing homes and in prisons and in meat packing plants and similar. And we will have flares, I think, and we will really be tested in our ability to withstand this virus. I think it is the right time to begin opening up society. This has to be done very carefully. It has to be done differently in different areas because this epidemic is not proceeding in the same way in all parts of the country. And what's appropriate for a rural county in Missouri is not necessarily appropriate for New York City at this point in time. And I think very important philosophically, we all have to work together. We have to try things. We have to analyze the experience. We have to be ready to change course and hopefully not tear each other apart in the process, but work together to find the approaches that work the best. And I think I talked about a little bit in the last talk. It's very important for people to understand their own personal risk profile, because we know that not everybody is equally at risk for getting extremely sick with COVID. We know that age, especially over the age of 55, over 65, is a very important risk factor, and that people in the older age groups tend to experience more severe disease than people in the young age groups. We also know that even young people can get very sick, but on a percentage basis, if you map out the percent of hospitalization or the percent fatality rates, it's much, much higher in the elderly. And we see statistically most of the fatalities that are occurring are in people in the elderly age group. So that's an important consideration. We also know that underlying diseases render a person more susceptible to serious COVID. Those underlying diseases are serious lung diseases, serious heart diseases, diabetes, obesity, probably immunosuppression, probably cancer, active cancer, and just a debilitated state for whatever reason. Those are all things that make a person more vulnerable. And so we have, on the one hand, young people, maybe people in their teens or 20s who are in good health, who might choose to take some risk of experiencing COVID with the expectation that their infection will probably be mild, and that might be reasonable. And on the other hand, we have people in their 70s with underlying diseases, and they are really going to need to protect themselves very carefully, I think, for a number of months to come. So when will people be able to re-enter? I think it's not something that we can make a generalization about. I think people are going to have to be careful and make judgments based on their own risk profile, and very importantly, the risk profile of their household contacts, because we do have to recognize that with a contagious illness like this, households are in this process together. And if one person in a household has the infection, it may be difficult to prevent it from spreading to others in the household. So a household has to be assessed based on the most compromised individual in the household, and that determines the risk for that household. So I And I think that we have to recognize that we're on the probably beginning to be on the downside of this epidemic, but it may be a gradual downslope. And I think we have to recognize that there is potential for another large wave. That has happened with other pandemics. And the fact that our serologic testing is showing that probably about anywhere between 5 and 20% of people so far have experienced this infection means that on the other side of the coin, the great majority of people have not experienced it, meaning that there's still a large pool of susceptible individuals out there who are fuel for the fire, basically. And so we have to at least take into account the scenario that we have improvement over the next few months and then have another large wave in the fall. A sobering thought, but I think realistically, we have to keep this in mind, and our health planners are, I think, planning for this kind of scenario. So with that, I hope I haven't depressed you too much. I'll stop and be very happy to take your questions on any of the areas that I covered or anything else you'd like to talk about.
All right, Dad, thank you. That was excellent and very informative. I did have many questions that were already submitted and many more are being submitted online. So we can go ahead and get started here's one of the first questions that came to my email. What is the current known risk for pregnant women? Is one trimester more at risk than the others?
Okay, that's a good question. And you probably remember that with the H1N1 influenza, it turned out that pregnancy was a very important risk factor for severe disease. I don't think we've really seen that so far with COVID, but you have to recognize that experience is really still pretty limited. And so I think the jury is still out on that question. But so far, it has not emerged as one of the really serious risk factors for serious disease.
Okay, thanks, Dad. Here's another. Since all tests I've heard of so far have many false positives and false negatives, and since apparently the presence of antibodies to COVID-19 do not mean one cannot have a return or the infection again, is there anything at all to do except continue strict isolation, use of masks, gloves, etc.?
Okay, Rachel, I missed the very beginning of the question. Sorry.
Oh, sure. No problem. It began, since all tests I've heard of so far have many false positives and false negatives. Okay. And since, and then continue on.
Okay. Well, the false positives and false negatives apply probably more to the viral tests. And the good news is there probably are not a lot of false positives, but there certainly are false negatives. So that's important to keep in mind. With the good antibody tests, there are probably not a lot of false positives or false negatives. These tests, we have lots and lots of experience with antibody tests in other areas of medicine, and we do have the capability to produce very good antibody tests, but there are nuances, and that's why not all the tests on the market could be considered good. But if you're dealing with one of the good tests, such as the Abbott test, then you can have confidence that a positive test does mean that you have antibodies, meaning that you've experienced COVID. And if you have a negative test, it's possible that you were tested too early, but other than that, you don't have antibodies and you still have to consider yourself susceptible. Now, the questioner is absolutely right that at this time, you cannot conclude from a positive antibody test that you're immune. We have a hope that we'll get to that point. And then we could identify a group of people who might be, the people who could really be on the front lines with a little bit less concern than some other people. Or conversely, we could identify people who are negative who need to be protected. But we are not there yet. And so it means that you should not alter your behavior based on the antibody test right now. You may want to get the antibody test done because it may help you clarify if you had symptoms for several weeks, it may help you clarify whether those symptoms were the result of COVID or not. But you can't really use it as an indicator that you're free of risk from future infection. That may come, but we're not there yet.
And are there other measures to take besides the isolation and masks?
To prevent infection or to prevent spread? Well, I think we've recognized that what are called the non-pharmacologic measures really are effective, and those include, first of all, of course, trying to avoid contact with other individuals who are infected. In general, avoiding contact with other people as much as possible. The safest course for a person who's high risk is to stay at home and not see other individuals. And then hand washing, of course, is very important. Masks, I think, can be important. They're especially important for preventing an individual who has the virus from transmitting it to somebody else, but they're probably partially effective in preventing a person who doesn't have it from acquiring it. So all of those things, I think, are important. And then, of course, in the setting of a hospital or dealing with a person who is actively infected, then there are all the personal protective measures that are important in that setting.
Mm-hmm. Okay. A question came in about remdesivir, and the question was whether it might be possible if remdesivir could eventually be part of a cocktail of drugs that fight the virus, akin to what we see with HIV.
Yes, exactly. What we've learned very importantly with HIV and with hepatitis C, which are tremendous success stories for antiviral therapy, is that cocktails of drugs are often more effective than one drug at a time. The cocktails often have the effect of attacking the virus in two different ways, and they're also effective at preventing the virus from becoming resistant to the drug. So we certainly do look forward to the time when we have additional agents that we can combine remdesivir with. And an important question will be, could hydroxychloroquine, for example, be a drug that could be combined with remdesivir? So this is definitely something that will be explored as we move forward.
Okay, terrific. A question came in from parents in our synagogue community who have a young adult child, and the question related to whether it would be safe for their adult child to live with roommates in the city.
Yes, well, you're only as safe as the riskiest person who you're living with. I mean, everybody within the household environment, even if it's roommates in an apartment, it's quite difficult to block transmission in that setting. There's certainly precautions that can be taken, but you have to recognize that there is significant risk of transmission when people are living in the same unit together. And so the risk to individual A, let's say you have individual A and then individuals B, C, and D all living together, the risk to A is related to the practices of B, C, and D. And so if any of those individuals are in high-risk situations, let's say they're on the front lines in a hospital and being exposed to lots of people with COVID, then that creates a risk for individual A. Now, if everybody there just stays indoors and is not exposed to any risk, then the household as a whole will be low risk. So it really depends on what the members of the living group are doing.
Mm-hmm. Okay, this is an interesting question. Somebody emailed, what is the size in inches of a virus?
Well, of course, the viruses are submicroscopic, meaning you can't see them with a normal microscope. And they're measured in microns, which are millionths of a meter. And a meter is 3 feet. So we're talking about something, hundreds of times smaller than a bacteria. And it requires an electron microscope to visualize.
Okay. Someone asked by email, how confident are you, or do you think that the virus will likely mutate?
Okay, that's an excellent question. All viruses mutate, and we're very familiar with that happening in influenza. And each year we have a new strain that's partly the result of mutations in the virus. Now, COVID, one of the few bits of good news, is a little bit slower to mutate than some other viruses. It actually has mechanisms within its machinery to counteract mutations. So it does mutate, but at a much slower rate than flu. And so that may be less of a factor than for some other viruses. But once again, it's certainly something we have to keep an eye on very closely, especially with regard to drugs like remdesivir. I will say in the laboratory, it has not been quick to become resistant to remdesivir, and the viruses that are resistant to remdesivir seem to be less able to reproduce themselves, and that's a good thing, and suggests that resistance may not be too terrible a problem for that drug, but that remains to be seen.
Okay, another question that was asked is your opinion on when it might be safe to travel in an airplane.
Wow, that's a very tough question. I think it really depends on how much of the infection, how common the infection is in our population. You have to recognize that when you get on a plane that you are interacting with dozens or potentially hundreds of other individuals, and you're mingling with them in the boarding area, you're in the confined space of the plane itself, you may be mingling with them afterwards and in collecting baggage. So these are all high-risk situations. Now, the air in airplanes is partly filtered, and that's a good thing. In the SARS outbreak, this was studied carefully, and the main risk on planes was to people who were 1 row or 2 rows ahead of somebody with the infection, not everybody on the plane. But on the other hand, COVID is more contagious than SARS was. I think we're going to have to go slowly on that. And surely we're going to have to undertake precautions like passengers wearing masks, crew and stewardesses wearing masks, and stewards, and probably screening people for fever before they get on the plane, and probably keeping the planes from being crowded. So I think there's going to be some risk as long as we're really dealing with the infection. If we can get down to the point where there are very few infections occurring, then the risk of traveling by plane will diminish. But for a while, I think airplane travel is going to be risky, or at least not risk-free.
Right. Okay. Thanks, Dad.
This is where people really have to be familiar with their own risk profile. And for a young person with no underlying diseases, they may choose to undertake this risk. But for a person who's at much higher risk, they may want to be much more careful.
Okay. The next question that came in may also relate to personal risk profile, but I do think it's the kind of question that many people are wondering, and I'm going to read it. I have stayed 6 feet away from everyone for 7 weeks, confined to my apartment alone, except when having to go to the grocery store or 1 or 2 other essential things. When I go out, I wear a mask and gloves and even a little ozone-producing air purifier around my neck. I am following all rules for the groceries and other things that come into my house. When can I see my 96-year-old mother and my adult children and my grandchildren? When can I hug them?
Okay, this is a very good question that you're right. I think many people are asking. And I'm just going to say, I'm going to take a somewhat hardcore infectious disease position on this. And I would say that the precautions that the person is taking are good, but they're not perfect. The only perfect precautions are staying indoors all the time only with 1 or other individuals who are taking the same level of precaution, and to be very careful about anything that comes into the living unit. As soon as the person goes out of the unit, and particularly goes into an environment like a store, then they're starting to take on some risk. I think the use of the mask is helpful. Going to stores that are not crowded is helpful. Being in the store for as little time as possible is helpful. All of these are things to do to lessen the risk, and people may have to do this. They may not be able to get essential items without doing that. but they also have to consider that they have some chinks in their armor and they may not be completely protected. So now, if we translate that to the situation of exposing another individual, once again, consider the risk profile of that individual. If it's a person who's very high risk, you really have to factor in that you are not guaranteed to be free from the virus with the precautions that were described. On the other hand, if a person, and you may choose to not take the risk. On the other hand, if the potential exposure you're talking about is to a person with a low risk profile, and that person knows, then you, between the two of you, you may choose to undertake that risk.
Okay, thanks, Dad. Okay, here's a question that was submitted during the Zoom. Can I really get COVID if someone in front of me sneezes on the street? Social distancing is very difficult in New York City, and I'm scared when I see so many faces uncovered and many homeless who have uncovered faces on the street.
Yes, well, our understanding of the transmission of COVID is that it generally requires a more prolonged exposure than just an instantaneous exposure. Generally 10, 15 minutes of being within 6 feet of a person who's infected is thought to be required for transmission. But, you have to use common sense here. And if somebody who is infected sneezes directly in your face, that would not be a good thing. I think there would be a risk of transmission. This is where I think the use of a mask is important. The mask, as I mentioned, is more helpful in preventing you from transmitting to somebody else than in preventing you from acquiring it. But on the other hand, what the mask can do is it can block some of the large particles. And so the output of a sneeze, sorry to get a little graphic here, but the output of a sneeze, a lot of that consists of large particles that may be laden with virus, and if the person is infected, and the mask will block some of those particles. Now, be careful because the mask may be contaminated then, and if you touch the outside of the mask, you may get the virus on your hands, but it may at least be somewhat effective in blocking the infectious material from getting into your respiratory system. So I would wear a mask anytime I'm outside, unless I was sure that I was not going to be within 6 feet of other individuals. And this is a special problem for New York, and probably this is one of the reasons why New York is so severely affected by the outbreak. That population density is something that works to the advantage of the virus, and you have to try to avoid those very dense situations. I know I'm giving advice that may not be practical to carry out, but I think this is one of the real difficulties that New York faces as it tries to renormalize that people have to, that mass transit poses certain risks. Walking on the sidewalk, being in building lobbies, being in elevators, all pose some risks of transmission. So I think these are difficult issues that we're going to have to really think about.
Okay, great. Here's another question that came in on the chat. I've seen studies saying that a child can be asymptomatic and transmit the disease to others, including adults. I've also seen other studies saying that there aren't demonstrated cases where children transmit the disease to adults. What is the best science on this, and what are the implications for reopening schools?
Yeah, it's a very good question. Partly we're working on the analogy to influenza. In the case of influenza, children get infected very readily. The infection spreads readily in the setting of schools, and we know that schools serve to amplify the infection, and then the kids can bring it home and transmit it. We also know that closing schools can be effective in decreasing the transmission of influenza in the community. Now, what do we know about COVID? We do know that children become infected. We do know that the levels of virus can be pretty high in the children. We also know that they typically don't become sick or just develop a mild illness. But what we really don't know is whether they transmit the disease effectively to other individuals. It is just a question mark at this point. We don't know the answer to that. And that means that I think we really don't know the importance of closing schools as a control measure here. If it turns out that they really are good at transmitting the infection, then yes, then schools will be important, and keeping kids out of school will be an important control measure. But it may be that it's not that the kids don't bring the infection into their households. And it's only going to be future research that allows us to determine that. Unfortunately, we just really don't have the answer to that question right now. I think it's prudent to be quite careful, because we do know that the infection certainly can spread among children, and that they can have the virus in their respiratory secretions, even at times when they're not showing any signs of illness.
Okay. Another question that came in was, would you recommend to an expectant mother that they might consider a home birth versus going to a hospital?
I'm sorry, was that a home birth?
Yes.
Okay, well, that's an interesting question. And I think it really requires a balancing of the advantages and disadvantages of the home birth and the advantages and disadvantages of the hospital birth. Certainly, if the woman has any complications of the pregnancy, if she's high risk for whatever reason, then it's more important to do that delivery in the hospital rather than at home. If the woman is, if it seems to be routine, the woman is in good health, and she's participating in a good program for doing home births, that is something that could be considered. Now, I think the hospitals are getting smarter every day about how to prevent this infection. Little by little, the intensity of infection and exposure in the hospitals, even in New York, is going down. The woman, I think, would want to consider the specific hospital that she's talking about and how much COVID is present in that hospital, and try to put all of these risks together. I would say that, and this applies across the board, not just to pregnancy, if a person really needs to be in the hospital, then it's probably best to do that and hope. And I think the hospitals are certainly trying very hard to do everything they can to minimize the transmission from COVID patients to non-COVID patients.
Okay, great. This is a great question that just came in. I've been wondering this myself. I get all my groceries delivered. Do I need to disinfect everything I bring in? I hear the virus can remain in plastic and paper.
Yes, so many people are asking this question. I don't think we have the answer. We know that the best way to get this virus is to be in contact with another individual who has the virus. But we are concerned that, as the questioner asks, that the virus can stay alive on surfaces from anywhere from some hours to several days. And it is possible, we don't know for a fact, but possible that exposure to that kind of virus on surfaces could get onto a person's hands and then be introduced into their respiratory tract and cause them to become infected. Now, it is again possible that groceries might have the virus on their external surface. So if a person wants to be ultimately careful, they could disinfect the packages, and there are all sorts of ways to go about this, but try to disinfect the outer containers of anything coming into the house, and then and then feel safe that they've killed any virus. But whether this is really necessary or not is really an unknown. And certainly another tack is for items that are stable to leave them outside of the house for a day or so, or several days, before bringing them in, because the infectivity of the virus will go down over time.
Thanks, Dad. Here's another question. Why do you think that the United States has so many more cases of COVID than other countries? Other countries also have cities where proximity is hazardous. Why is New York such a hot spot in comparison with other large cities?
Okay, this is a complicated question. Now, the first thing I want to say is that we have to not just look at the numbers, but you have to correct for population size. So epidemiologists think in terms of rates. What are the number of infections divided by 1,000 or 100,000 people, and then compare different countries. When you do that, the United States is somewhere in the middle, or some maybe a little higher than the middle, but not absolutely the highest by any means, either in terms of the rate of infections or the rate of deaths. On the other hand, we have examples of countries. Some of the countries in Asia have been quite successful. New Zealand is another that is raised, appear to be successful in controlling their infections. And what is the difference? Well, I think there are a number of things. Even in the United States, I think we can see differences. That California appears to have, in general, so far, been more successful in controlling the spread of COVID than areas on the East Coast. And I think it has to do with how early in the course of the infection the precautions were introduced. It has to do with how thoroughly the precautions were introduced and follows. And it definitely has to do with the density of the population, because an environment like New York City is simply more challenging from the standpoint of blocking transmission of an infectious agent than an area that is less crowded. And there is another factor too, which is the extent to which the area is networked with other areas. This virus came to us from other places, and New York is a place with constant introduction of people from every other country in the world. So the intensity of a virus coming into New York in the early phase of this epidemic was probably greater than any other place in the United States. And so the virus probably got seeded very thoroughly into New York at a very early stage, more than in most other places. So I think all of those are factors that account for the very difficult experience that the United States, that New York in particular has had. Now, if we talk about the United States as a whole, we could spend a lot of time talking about this. There were, I think, issues in taking a little longer than we could have in getting precautions underway. And I think we did not do as well in some other countries at marshaling our resources, at communicating within our government, among our government agencies, and so forth. But that's a complicated discussion.
Right. Okay. Thanks, Dad. This was another specific question that came in. Is it advisable to see new people in small gatherings, meaning less than 10 people, for example, if the people have generally been following stay-at-home guidelines, but not quarantined in the New York City or downstate New York area? Are there recommended precautions? Would you recommend that they stay outside, 6 feet apart, wear masks, don't touch, etc.?
Well, I think in New York or even in St. Louis, it's premature to do that at this point in time. We should not be gathering people together. The more people you gather together, the more chance you have that one or more of those people will be incubating the infection. And we have the unfortunate reality that people are contagious for several days before they develop symptoms. And some people may just be asymptomatically infected and go through a period of time of a week or a couple of weeks where they're contagious without showing any signs of infection. So what you're describing, I would see as still a hazardous activity, and that should not be done. And I don't think that government authorities, public health authorities, at this point want that to be done in the New York area or in the St. Louis area, for that matter. Now, I think public health authorities everywhere are trying to now determine what the steps are and what can be done safely as we start to allow people to congregate and relax other measures. And I think the outdoor environment will be safer than the indoor environment simply because of much better ventilation. It will be important to maintain social distancing for sure. And it may be important to maintain masks as well, certainly indoors and quite possibly outdoors as well. And the size of the gathering is going to be important as well. So all of those things. But right now, I don't think we should be gathering people together.
Okay, thanks, Dan. Here's another question that came in on the chat. Will those who contract the virus, do you believe that those who contract the virus, will they have a natural immunity that might guard against future mutations of the virus?
Well, we hope so. We hope that having this infection produces immunity. But once again, we don't know the answer to that question. I would say it's a good bet. Many more viral infections than not, people are immune, at least partially, and at least for a period of time after the infection. But there are some important examples where that's not the case. So unfortunately, we just have to wait and see on that question.
Okay. Another question is, have people who reported getting COVID gotten it again? And how long are you contagious?
Yeah, okay. So let me take the second part of that first. People are contagious probably for about 1 to 2 weeks. It will vary somewhat from person to person how severe their infection is. The CDC allows people to begin going back to interacting with other people when it's been at least 7 days from the beginning of symptoms and at least 3 days of no fever without any anti-fever agent and all other symptoms getting better. Some other people recommend adding another week onto that just to play it safe. Then we're talking about 2 weeks. So we're generally talking about a period of 1 to 2 or maybe a little more weeks when people might be contagious when they have COVID itself. Now, as to whether people can get it a second time, I am so far not aware of any documented examples, well-documented examples of a person having COVID twice. We have to recognize, though, that we're talking about a pretty compressed time frame at this point, and we really need to let more time pass so people will have the opportunity that there will be a group of people out there who have had it where it's been documented and where they get exposed again, and we find out if any of those people have second infections. So that's the reason why this is still a somewhat unknown question. So no, I'm not aware of any documented second infections yet, but I don't think the answer is in.
Okay. This was a question that came in during your presentation, I think looking for a little bit of clarification. They were asking for clarification regarding your comment that it appears that we're on the downside of this, although you did say that we could see another wave in the fall. And so where they're looking for some clarification is, are you talking about New York only? And the person asked because they said that nationally there were record daily deaths this weekend, even though we are seeing numbers go down in New York and New York City.
Right. Well, I think we're talking both nationally and in the New York area that we're starting to be on the downside. I think it's still pretty early. You have to recognize that deaths are what you could call a lagging indicator. People often, unfortunately, when they die, they may not die for 3 or 4 weeks after they have the infection. So the number of deaths, reflects the activity of the infection several weeks earlier. What we really should be looking at is newly diagnosed cases and admissions to hospitals, possibly admissions to ICUs. And when you look at those metrics, it's beginning to be somewhat encouraging, but we have to be very careful because if we relax precautions too soon, we could have an immediate rebound, we could have a second wave later on.
Okay, great. I'm going to go, there are many more questions, but I'm going to take just a couple more because I think, we're getting long, but here, there are some excellent questions remaining. One question is, and of course, this is very important for any parent who's thinking about the summer ahead. It also possibly relates to our mikvah and other synagogue mikvahs. Is the virus transmissible in water, such as a shared pool?
Yeah, that's a very important question. And one of the few good things about COVID is that it's very susceptible to disinfectants, including chlorine. So if there's a mikveh or a swimming pool and it has proper levels of chlorine or bromine, then the water itself should not transmit the virus. But of course, you also have to consider the environment around the pool and recognize that if there's a person who's infected, they might contaminate the railings or the chairs or whatever else it might be, so that you're still going to want to be quite cautious, and the environment should be cleaned thoroughly and on a regular basis to try to prevent and spread from environmental contamination.
Okay, great. Here's another specific question that was asked. My mother is 90 years old. She has a home health aide who works in a hospital but sleeps and cares for my mother in her home. Is this safe for my mother?
Yes, so it's an important and difficult question, and you really have to get down to the level of detail of what the exposures are to the home health aide when she's at her work in the hospital or outside of the hospital as well, what her personal exposures are. If she is somehow in a very low risk environment within the hospital, then the risk is small. On the other hand, if she's in a situation in the hospital where she is not in control of the risk, if she's interacting with a significant number of patients, then there is some risk involved in that situation, unfortunately.
Okay. Is there any kind of general consensus on how long you need to be exposed to the virus to get it? The person who wrote the question said they believe it might depend on the severity of the virus.
Yes, well, as I said, the general sort of generalization out there is 10 to 15 minutes of exposure within 6 feet to a person who's infected. But I think, obviously, as with any kind of statement like that, it's something of an oversimplification. And if you were immediately adjacent to a person who was infected at a very contagious stage of their illness, and they coughed directly in your face, and that only took 15 seconds, I think you could still become infected. So you really have to consider how close you are to the person, but also you have to consider the duration of the contact. You have to consider the ventilation of the place where it's taking place. Outdoors is less of a concern than indoors. And you also have to consider what the person who might be contagious is doing. So if they're talking, and if they're talking loudly, that can spread the virus. If they're coughing, if they're sneezing, if they're singing, all of those things will increase the extent to which they're putting the virus into their environment. So all of those things need to be factored in.
Okay, I'm going to do just 2 more. Somebody asked, is it risky to open the windows in your apartment? Could the virus enter through this route?
No, I would say the balance of risk is more in favor of keeping the windows open than not. If there's any question of somebody within the apartment having the virus, because that will improve the ventilation and lessen the likelihood of exposure. The frequency of the virus in the air, just in general air, is very, very low. And the chance that somebody would be infected from virus just blowing into their apartment is exceedingly low and really negligible.
Okay. Similarly, just a follow up to that, and then I'll do one more, is if this person asked, if you live in a co-op or condo building, could COVID circulate through the vents? Yes,
this is a good and difficult question. We don't completely know the answer to it, but unfortunately, I think we have to be a little bit careful, that we have to, have some awareness of what the ventilation system is. And you could just imagine a circumstance where, let's say, there was a party room in the lobby and a number of people in there who were infected, and the way the air was transmitted was directly from there to living units on the next floor or 2 floors. There might be some risk of transmission. I think it would be a lower risk than if you were actually in the room with the infected people, but I don't think it can necessarily be ignored, unfortunately.
Okay, and a final question, and I apologize to those who did not have their questions answered. I can try and work with you if you want to follow up with me to get answers for you, but just because we're getting a little long on time. So final question, can an animal be infected and become contagious?
Okay, we do know that some animals can become infected. In fact, of course, we think this came from animals, but it does look like cats can become infected, and possibly dogs as well, although so far it looks like cats are more susceptible than dogs. What we don't know is whether those animals can be contagious to other individuals. Now, it's also probably true that if a cat or dog is living with a person who's infected, that the animal's fur may become contaminated with the virus, and if another person, touches the animal, that may be a way that they could pick up the virus. So the animals almost for sure can play a role of passive transmission, and it may be, but it's really an unknown whether they can play a role in active transmission. Probably they're much less important than the infected humans.
Okay, Dad, thank you very, very much. There are still several excellent questions remaining, but I think this could probably go on for a very long time. Rabbi, are you still there?
Yes.
Would you like to say anything? Dad, thank you very, very much.
My pleasure.
Appreciate it.
I hope it was helpful.
Thank you so much, Dr. Storch, as always, for your thorough, informative, and poised presentation. It's a great asset to our community that you're able to offer your time to us.
It's my pleasure to do it anytime.
Your skills are passed to your daughter. So thank you, Rachel, for doing an excellent job in moderating, as always, and the same qualities that your father has. I just wanted to conclude by adding one point to the discussion, and that is, although Dr. Storch told us the reality, and as he himself said, the reality could be daunting, appear daunting, and challenging and uncertain. The picture of the future is blank. We just don't know. So of course, we have to take all precautions and follow the medical guidelines. It's also important to remember that we as a community of faith live on two planes. We live on the plane of the worldly affairs, the medical plane, and we also live on the plane of faith. And it's very important to remember that we put the Almighty into the picture. And as the doctor mentioned, there have been cases, even in the recent past, the modern times, where things were potentially looking bleak in terms of epidemic and challenges, and somehow, thank God, it quickly turned, and we don't necessarily fully understand why. So as a community of faith, we believe that ultimately the divine is in charge. And it's important not to lose hope and to have despair, as difficult as it may seem, because there's precedence for challenging situations to turn very quickly throughout history, throughout Jewish history, and even in current medical times, as the Dr. Storch pointed out, there is precedence for this matter. So as we take our precautions and we understand the reality and the dangers, we also must remember to turn to our Siddur, our prayer book, our book of Psalms, to remind ourselves that ultimately Hashem is in charge. Hashem is a merciful deity, a divine being, and with his help, please God, we'll get through this just like we got through other situations in the recent past and in the distant future. So it's a very important thing that hope is not lost, and that everyone has to realize that this will come to an end. I can guarantee it, and life will somehow return back to our normal way of life, please God, in the near future.
Yes, that's a beautiful conclusion.
And so I want to thank you once again for your time, and Rachel and everybody in the whole community should please be safe, and we are here for you. That is our main message that we're trying to relate to you. We are here for you, and we'll continue to be here for you. And if there's anything we could ever do for you, please don't hesitate to reach out to any of us, and we'll do our best to stand by your side during this difficult time. Everyone should have a wonderful evening. Thank you so much for joining us.
Thank you, Rabbi.